Hello, everyone. It gives me a great pleasure and honor to give this lecture on this bone marrow failure subcommittee session. And the topic I've been given is to look at the diagnosis and treatment of aplastic anemia, a predominant focus on resource-limited countries and also amidst this COVID-19 pandemics. And many thanks again for Dr. Andrés Brodsky and also the other committee members and the EHSH committee for asking me to present this topic. So we all know that aplastic anemia is a pure autoimmune disease, and it's a disease quite, if you look at it, it's a quite simple disease with normal bone marrow producing the hemopoietic stem cells and all the cell lineages, immune dysfunction or an immunosuppressive attack on the marrow, leading on to contraction of the stem cell pool and leading to marrow aplasia and cytopenia. And this is the paradigm of a simple autoimmune disease where the target organ is the stem cells or the hemopoietic stem and progenitor cells, which leads to this manifestation of pancytopenia. And it's still a disease with an incidence of around 2 per million, with the incidence going up to 4 per million in countries in the Far East. And this has been elegantly shown by a number of works, predominantly from NIH, dating back to 2010 using confocal microscope. And we all know that this is a disease of immune pathogenesis because we are aware that the CD8 T cell population is quite a cytotoxic CD8 T cell population is immunosuppressive to the hemopoietic stem cell, leading on to apoptosis and bone marrow failure. But we had a significant interest in looking at the CD4 subsets, predominantly the T regulatory cells and Th1, Th17, the later two leading on to expansion, and also to look at the number of cytokines implicated in the pathophysiology and the understanding of the disease. But the important things when we are faced with patients presenting with pancytopenia, and as hematologists, the first thing we would want to rule out is an acute leukemic process or an infiltrative process. But once you arrive at a diagnosis of aplastic anemia, and we are aware that aplastic anemia is a diagnosis of exclusion rather than having specific diagnostic features. And 10 to 20% of these patients could have a constitutional or an inherited predisposition, which can be seen in patients presenting with mild to moderate cytopenia with minimal cytopenias as well, with a hypocellular marrow. And it's important to rule out a constitutional component to it, because that has got major implications for subsequent treatment prognosis, genetic counseling, family planning, and number of other aspects down the line. So what would you do when you're presented with a new patient with pancytopenia? You would want to look at an extended history to make sure that there is no previous pre-existing blood counts in this patient, any family history of leukemia or aplastic anemia, cancers in the family, lung fibrosis, liver cirrhosis, because these could be pointers towards underlying telomeropathies, which can be very subtle, and also trying to look at the consanguinity and looking at the pedigree and the family tree. And we will also want to look at specific questions related to the type of aplastic anemia. Is it related to a drug-induced? Is it related to a post-hepatitis aplastic anemia? Or is it related to an underlying constitutional predisposition with some of the features as indicated in the table there? This is important because we would want to make sure that this patient does not have any other alternate diagnosis. Number one, make sure you comprehensively evaluate these patients to rule out other reasons for their pancytopenia, to look for other clues which could help us to delineate whether these patients have an immune or a genetic type of constitutional inherited bone marrow failure. And also important in the management that these patients have regular platelet increments done to make sure that these patients have good increment in their platelet count post platelet transfusions, either apheresis platelets or pooled donor platelets as well. But we know that this field of inherited predisposition both to aplastic anemia and also familial MDS AML has expanded in the last 10 to 15 years, with newer genes being implicated in the causation of pancytopenia and bone marrow failure. And one of the examples which I always give is this DDX41. We've always been conventionally taught that if a patient is age 40 or 50 or 60, do not even suspect an inherited predisposition. But here we know that these patients do have the median onset of MDS, hypoplastic MDS, is in the age of 60 to 62. So age itself is not just a simple delineation. Although we are aware of these number of different subtypes of inherited bone marrow failures with hematological phenotype prior to the onset of the proper bone marrow failure or absence of a hematological phenotype, we are aware that nearly about 40 to 45% of patients do have an uncharacterized genetic defect, which means that there is a reason for their underlying bone marrow failure, but we are not able to find out. And this is just an illustration of the panel we use, bone marrow failure gene panels, which we use to look at bone marrow failure if they have pancytopenia or neutropenia or thrombocytopenia, or if you're suspecting a Diamond-Blackfan anemia or lymphedema, and one of the common ones being GATA2. Other way of looking at it is this data which was published a few months back, and it's important for countries where you would not be able to significantly look at an expanded spectrum of inherited gene defect. So this group from Dario Babishuk looked at this, and to look at three simple things: looking at the PNH clone, acquired 6p loss of heterozygosity, or clonal TCR rearrangement, to see whether we can delineate between an immune-mediated aplastic anemia versus a germline bone marrow failure. So here they were able to see that if you either have a PNH clone or an acquired 6p loss of heterozygosity, this would be only detected by SNP karyotyping, not by array-CGH or by conventional karyotyping or by FISH, because this is due to uniparental disomy at the HLA locus. You will see that if one of these is present, you are able to be confident enough to say that this patient has got immune-mediated bone marrow failure rather than acquired inherited bone marrow failure. And few other clues for this would be presence of PNH clone, as we indicated there, and also this aspect of mutational profile in aplastic anemia, because this is important, because when we first described the presence of mutations in about 20% of patients with aplastic anemia, I was quite surprised, because why would a pure autoimmune disease have such a mutational spectrum? And now we understand that in a significant proportion of patients with aplastic anemia, depending upon the techniques you use, you're able to identify either DNMT3 ASXL or BCOR or BCOR-L1 and PIGA mutations. And to confirm that, this is more commoner in older people, because this could be related to age-related clonal hematopoiesis as well. So this is how I look at it, the hemopoietic stem cells and depletion in aplastic anemia as either inducing mutations which could have or genomic abnormalities which could be good prognosis, poor prognosis, or neutral or fluctuant prognosis, leading on to different clinical spectrum. And this is also important because in countries, obviously, now genetic profiling or gene panels are quite commonly used. And it's important to understand that at the time of diagnosis of aplastic anemia, and this is 6 months after IST, most of the abnormalities you pick up are less than the 10% variant allele frequency. And we were able to look at around 96 patients with aplastic anemia, and most of them had a variant allele frequency of less than 10%. So here you can look at it. Most of these clustering of mutations or the variant allele frequency is less than 5%. And this is quite important because in conventional sequencing laboratories, they would not call these abnormalities, which sometimes is a good thing. And we know that clonal hematopoiesis is rife in a number of conditions, as illustrated in this chart, with different spectrum of prognosis as well. So one thing just to be on the clear side is that we should be clear that clonal hematopoiesis is extremely common in aplastic anemia. It is a rule rather than exception. It's very ubiquitous depending upon the techniques and the type of sequencing you use. And again, please do not make any clinical decisions based upon these mainly MBS-related genetic abnormalities. Just having a mutation does not mean to say that this patient has got MBS rather than aplastic anemia. And there is always a question when somebody presents with a non-severe AA or a moderate aplastic anemia, is this hypoplastic MDS or aplastic anemia? And we know historically it's not recognized as a separate entity in WHO. And the guidelines was based upon nearly 13 years back, and the number of cases were quite small. So what we did was, this was published in Leukemia a year back, looking at patients with cytopenia to look to see whether they had a high histological and a genetic score or a low score. And patients with low score, but still classified as hypoplastic MDS, behaved more like aplastic anemia, while patients with hypoplastic MDS with a high histological and a genetic score behave more like a myelodysplastic syndrome, and again, able to segregate these two groups of patients. So here now we got an aplastic anemia patients. We now have tried to rule out whether there is an inherited predisposition. We made sure that there is no other alternate diagnosis, and this is not MDS. And treatment response, treatments of obviously based upon two simple facts: is it immunosuppressive therapy or hematopoietic stem cell transplantation? And the most of the treatment algorithms is based upon age of the patient. If they have an identical sibling less than 40, you'd go ahead with the transplant. But if they're more than 40, you go directly for ATG and cyclosporin. But if you're less than 40 with no sibling donor, then you would go for it. And this data comes from a number of studies essentially showing that 60 to 70% of patients following ATG and cyclosporin, predominantly HOS ATG and cyclosporin, will have a response. 20% of patients will relapse. 10 to 15% of patients will have clonal evolution. And some of the factors which are important on looking at the outcomes after ATG, as we know that partial response is more commonly seen rather than complete response. And it's also very important to note that the older the patients are, or the very severe the disease, the early mortality and morbidity due to the treatment, and also due to the complications due to the disease itself is high, that sometimes you can have up to 25% 6 months mortality in older people, and also up to 10% mortality in all age groups as well. And not only that, we need to look for late cytogenetic and other evolutionary things in the context of long-term monitoring of aplastic anemia. But unfortunately, till the last few years, we've not made a significant progress on the response to immunosuppressive therapy in this group of patients, because a third of patients remain refractory. And this is just to show a long-term data from one of the EBMT studies of ATG, cyclosporin, and GCSF, with an overall survival of 15 years of close to 60% in this 40 to 60 years, and more than 60 years overall survival of 50 years, nearly up to a third of patients being alive at a long term. So we've gone into this. If you're more than 40 or do not respond to ATG and cyclosporin, would you go for an unrelated donor transplant? So there are various transplant conditioning protocols for severe aplastic anemia, depending upon sibling or unrelated donor. But predominantly, it has got cyclophosphamide based, with high-dose cyclophosphamide with ATG, and cyclosporin and methotrexate being the GVHD prophylaxis, or if you're older than 30 years, or if it's a matched unrelated donor, there is use of fludarabine commonly along with cyclophosphamide and ATG. But we have always been quite keen to use fludarabine cyclophosphamide campeth. The advantages of that is that you can use peripheral blood as a stem cell source. You do not need methotrexate for GVHD prophylaxis, and the stem cell dose is quite high as well with good long-term outcomes. But one of the important things in aplastic anemia is that you need to use post-graft immunosuppression for a long period, up to 12 months or sometimes longer in these patients, to prevent graft failure. As indicated, we use this regimen of fludarabine, cyclophosphamide, and campeth for nearly 10 to 15 years, and quite a lot of experience is being gained in this regimen, with a recent update on predominantly focusing on the older group of patients more than 50, showing that you are able to achieve a good GVHD-free, relapse-free survival in this population, while in people less than the age of 50, it is extremely good with overall survival up to 96%. The only factors which had an effect was age did not come into a big factor when we looked at overall survival, nor did it on the GFRS, but it did have an HCT-CI had an impact on the overall survival. But important to note that autoimmune diseases are quite commonly seen post-campeth-based immunosuppressive therapy used in conditioning as well. So there are various pros and cons to this regimen of using campeth in the conditioning regimen. But there are still a number of unmet needs in aplastic anemia, predominantly in resource-poor countries as well, because treatment-naive population, we know that there is lack of robustness, durability, there is a time needed, and cyclosporin dependence and toxicity as well. Patients who are refractory become ineligible for transplant, and the elderly patients with a biphasic incidence being quite significantly affected, and which is why this data from the Swedish real-world group is important, because here the median age was 60 years with the incident as indicated, and you could see that only 10% of patients underwent transplantation. And if you look at people over the age of 60, the survival was quite dismal. And not only that, even in patients who received the treatment over the age of 60, the long-term outlook was quite poor. But if you look at this group, just in the people who received IST, it was quite poor, leave alone the patients who received cyclosporin alone or no specific therapy. And we're also aware that repeated courses of ATG, be it rabbit or horse or other types of ATG, do not induce significant responses, maybe up to 20 to 30%. But it's important to keep in mind that even in these group of patients, best supportive care or continuation of good infection prophylaxis, transfusions, and other things are quite an important aspect as well. So when we switch gears to looking at TPO receptor agonists, and when the first data was published nearly 6 to 8 years back, people were surprised that eltrombopag as a single agent in refractory relapsed aplastic anemia induced not only single lineage responses, but tri-lineage responses and improvement in cellularity. But it was important to note that in view of this refractory relapse setting, chromosome 7 abnormalities were something which we needed to be careful about. And when we looked at the UK real-world experience, you can look at it, the median age of this population was 67. And only 22% of patients in this older cohort responded to treatment, with some patients converting from PR to CR. And we showed some predictors of response. And in the real-world data collected through the EBMT in a number of European centers, you could see that physicians used eltrombopag in number of different combinations, different lines, and different treatment patterns as well, with an overall response rate up to 60% seen in this very heterogeneous cohort as well. So that is why this data is quite important, and needs to see the full data, which is looking at eltrombopag with cyclosporin as a first-line therapy in adults with severe aplastic anemia, with an overall response rate up to 46%, with responses being higher in people less than the age of 65, and very well tolerated with no deaths considered related to the study treatment as well. And quite a few patients qualified for transfusion independence, even in patients who did not show a CR or a PR by this criteria. So is L-Trombopac the only thrombopoietin mimetic? No, romiplostin has been used in Japan and South Korea and has been published in a few recent journals, and also a potential of using this drug called avatrombopag, which has got less food interactions and liver dysfunction interactions. And how does L-Trombopag induce responses in refractory and also in other settings in aplastic anemia? Could be multifactorial. Could it induce immunomodulation, promote tolerance? Could it have an effect on hematopoietic stem cells, or could it have an effect on the chelatory potential of it? So L-Trombopag, as we are aware, was used in the upfront setting as well, through this NIH data, which has been published, showing responses in this third cohort predominantly, or the triple drug cohort, showing significant responses with up to 60% CR rates and 90% overall response rate. But patients who responded to L-Trombopag unfortunately relapsed as well, with two different time points of relapse, predominantly in the people who discontinued cyclosporin at 6 months, but also at the later time point. But these relapses were being able to be rescued with either cyclosporin alone or L-Trombopag plus cyclosporin. And the recent update was published in Blood, showing a relapse rate of around 40% and a clonal evolution rate of around 15% for the triple drug regimen, with high-risk clonal evolution seen in around 6% of patients, which is why it was important to conduct this study, which is nearly about 10 years long now, looking at a randomized way of comparing ATG, cyclosporin, and L-Trombopag versus ATG and cyclosporin. And this is the patient disposition with 100 patients on each, around 100 patients on each arm. And you can look at the median age of this cohort was around 53, and a significant proportion being older, more than 40, nearly 60% of them more than 40 as well. And this is the primary endpoint, which was presented in EBMT last year, with a better CR and overall response rate at 3 and 6 months for the triple drug combination, with number of these patients having genomic abnormalities and even in the setting of aplastic anemia. We all know that androgens are used in aplastic anemia, not only in inherited bone marrow failure, as the next data shows, but also in acquired aplastic anemia, with number of different responses, but around 20 to 30% response rate seen for danazol or other anabolic steroids in this setting. So how does the treatment algorithm look? Age of the patient, presence of a sibling donor, or if you're older, don't have a sibling donor, you would go in for a immunosuppressive therapy with cyclosporin or with L-Trombopag. But if you have a donor and no response and donor, you go for an unrelated donor transplant. But if you do not have a donor, then there is a potential of using L-Trombopag. Other various combinations are in clinical trials using different combinations of treatment as well. So to conclude, I would say this is a disease which had a survival of around 10% in the 1960s, but we've significantly improved to around 90%. L-Trombopag is used in refractory and also in the upfront setting as well, but still therapeutic vacuum lies in older patients. We do not know what the ideal combination for these patients, or duration of treatment, or the dosage, and how soon after ATG if they are able to have ATG as well. And it's still important that we need to continue to look at the mechanisms of action and monitoring of clonal evolution. So with that, I'll stop, and happy to acknowledge a number of people as indicated in the slides, but also members of the EBMT and also a number of other people. So I'm happy to stop here and take questions when we have the discussion. Thank you.